Hello, everyone. Thank you for joining us. Welcome to the Avexia webinar series. Our topic for today is Understanding Insulin Resistance. My name is Christopher Chu. I'm the Director of Marketing for Avexia Diagnostics, and will be your host for this webinar. Today, I have the distinct pleasure of being joined by an exciting guest, Amanda Jones, who will be our presenter for this webinar. Amanda serves as the lead instructor of blood sugar regulation and digestive health at the Nutritional Therapy Association. She holds an MS in Human Nutrition and Functional Medicine, a BA in Communications, and is a certified functional nutritional therapy practitioner, certified ADAPT functional health coach, and licensed massage therapist. She has over 15 years of experience working as an allied healthcare provider focusing on digestive and cardiometabolic health. She is the founder of Health Atlas, where she leads an eight-week program for women at high risk of cognitive decline in applying the top evidence-based diet and lifestyle strategies for health brain aging. Without further delay, I will now turn the webinar over to Amanda.
Hello, everyone, and thank you for having me, Avexia. My name is Amanda Jones, and I'm a lead instructor at the Nutritional Therapy Association, where I help lead students through a 12-month program where we teach a science-backed approach to holistic nutrition with a real emphasis on bio-individuality. In our program, we use a framework of 5 foundations of health, which includes nutrient-dense diet, sleep, stress management, blood sugar regulation, and digestion. And I teach the portions on digestion and blood sugar regulation. And what we have found is that our students and their clients are intensely interested in a preventative, proactive, data-driven approach to metabolic conditions. So we thought it might be fun to share some of the material that we are teaching in the classrooms on insulin resistance with you here at Avexia. I know most of you will be familiar with this handy analogy of the door and the key, where insulin is like the key that unlocks the door to the cell and allows glucose to enter, which is great for clients, but of course when we zoom into that physiology, it gets a lot more complicated. So we know that our insulin receptors are transmembrane proteins. So we have this portion that's sitting outside of the cell membrane. Once it gets activated, it goes through this process of autophosphorylation that then triggers intracellular signaling pathways, also called secondary messenger systems. And they are full of all sorts of different enzymes and different pathways that we could analyze. But the way that I want to look at it today is these 2 primary pathways are PI3 kinase pathway, which is really all about metabolism and handling our energy balance in the body. And then we have the MAP kinase pathway that is a mitogenic, or all about cell division. So this is about growth and proliferation. So once these pathways are activated within the cell, then we're going to be able to regulate postprandial glucose levels as kind of a primary outcome, of course, but it's also triggers a broad array of anabolic signals. I think that a lot of us are conditioned to think about insulin as being negative because we're living in an environment now that has so much caloric availability and so many high glycemic foods that clinically, insulin comes up as a problem, right? But in and of itself, insulin signals really, really, really helpful functions in the body. It's like saying, make hay while the sun is shining, right? It's telling the cells that we have supplies, we are in an abundant world, and it's time to make things. So it's anabolic, it's triggering the synthesis of larger molecules from our basic micronutrients and macronutrients coming in from the diet. So it's not that insulin or insulin's signal is the problem. It's really when we lose the ability to respond, when we become resistant to its signal, that's when we start to see all of our problems, right? So here's a diagram representing these two key pathways where we have insulin docking on that receptor. We're going to get some changing in the structure of the protein in the receptors that triggers this whole cascade of enzymatic reactions within the cell. Here we have that mitogenic pathway I was saying, the MAP kinase pathway, that is really leading to a lot of cell growth, cell division, mitosis. And then over here, we have our PI3 kinase pathway that is really more about metabolism, right? So synthesis of lipids from dietary glucose if we have extra, synthesis of proteins like skeletal muscle, synthesis of glycogen so we can fill up our glycogen stores in the liver and muscles. We also have different anti-inflammatory and antioxidant mechanisms that are triggered through this PI3 kinase that support cell survival. And over here to the far right-hand side, we also trigger these GLUT4 transport proteins. So this is where we finally actually get to glucose uptake. When this pathway is triggered, these GLUT4 proteins that are just kind of hanging out in the cytoplasm within these vesicles, they are triggered to go ahead and translocate up to the cell membrane where they can embed in that membrane and act as little doorways for glucose to actually enter the cell. Now, a really amazing thing about these GLUT4s is that we have a backup system to activate GLUT4. Now, this is primarily expressed in muscle tissue. It's in the heart tissue as well, and skeletal muscle. But this backup door is what's known as insulin-independent GLUT4 activation. So if we are working a muscle, this is based on muscle contraction, exercise, work, we basically have a secondary pathway by which we can stimulate GLUT4 translocation, even in the context of insulin resistance. So this insulin-independent translocation of GLUT4 becomes a very important therapeutic leverage point later when we start thinking about how to help support glucose uptake, I should say. So what happens when we have hyperinsulinemia, this constant high level of stimulation of that insulin receptor? Well, interestingly, these pathways don't actually become resistant at the same time necessarily. What often happens is that the MAP kinase pathway is overstimulated. It's remaining responsive or sensitive. So we get these amplified mitogenic signals, growth signals, which can be pro-atherosclerotic, pro-tumor progression, pro-inflammatory, and pro-weight gain. At the same time that we have this hyperinsulinemia overstimulating our MAP kinase pathway, we're getting resistance in this PI3 kinase pathway, which means we are starting to see less and less of that glucose uptake, less and less protein synthesis, and less of these other pathways involved with cell survival and reduction of inflammation and oxidative stress. So this is a double whammy, and it really explains a lot of the clinical manifestations that we see with insulin resistance. This is overstimulation of one pathway and resistance forming earlier in the PI3 kinase pathway. So what is driving this insulin resistance? I think the one we're most familiar with is high glycemic diets. It's kind of like going to the rock concert and coming away with hearing loss, right? We have this constant stimulation from a high glycemic diet, leading to high insulin output, chronically elevated insulin causing those cells to say, okay, we've done our best at handling all of this glucose. We don't need any more. We're going to start taking in those receptors. We're not going to express as many insulin receptors, and they're not going to be as sensitive. So that's a pretty key cornerstone when we're thinking about therapeutic approaches, is that high glycemic diet. But there's a lot more to it. Of course, we have endocrine disrupting chemicals that can change the activity of that receptor. BPA is a very well-known culprit here. Inflammation. We know that cytokines can alter the phosphorylation of that insulin receptor so that we don't get those whole secondary messenger systems and pathways triggered. Another big issue is sedentary lifestyles. And that's because if we are not moving, we are not utilizing that insulin-independent GLUT4 stimulus. So we're getting kind of a more and more glucose built up in the system, and it just worsens the whole dynamic here of insulin resistance. So we need to be moving in order to exercise that insulin-independent glucose uptake. Nutrient deficiencies is another big one. If we mapped out all of the enzymes actually involved in these pathways, it's a dizzying amount. And a lot of them, they need cofactors. Mineral cofactors are really common for enzymatic reactions, right? So intracellular magnesium is a very common one that's needed within these pathways. We see other vitamins like B vitamins that also have a cofactor function. Stress is a huge one. We know that cortisol induces insulin resistance. That's its job. Cortisol is helping us raise blood sugar so that we can get between meals without becoming too hypoglycemic, or deal with a flight or fight situation without passing out from hypoglycemia. So the nature of cortisol is to cause insulin resistance in several different body tissues. And so it does that by blocking this PI3 kinase pathway and inducing insulin resistance. So if you kind of look at this picture here, you can see, charting these mechanisms gives you a great map for how to design a therapeutic approach based on diet and lifestyle. So shifting here to thinking about assessing insulin response. There was an article several years ago in The Lancet called The Role of Glucose and Insulin Resistance in Development of Type 2 Diabetes Mellitus, Results from a 25-Year Follow-Up Study. This study, in their findings, said that the development of type 2 diabetes is preceded by and predicted by defects in both insulin-dependent and insulin-independent glucose uptake. The defects are detectable when patients are normoglycemic and, in most cases, more than a decade before diagnosis of disease. Isn't this interesting? It's saying that elevated glucose is actually a late indicator for insulin resistance, maybe even a decade late. So this makes sense as well. So, we don't know, if we're only looking at glucose, we don't actually know how much insulin is having to be produced in order to keep it all into storage, push it into the cells, right? So it's kind of like a beach ball that we're trying to hold underwater, and we need more and more and more pressure to keep those glucose levels in check, right? So we're not seeing that if all we're looking at is those fasting glucose numbers or a hemoglobin A1C. We may not be able to see that, our insulin is gradually ratcheting up in order to do the same amount of work that a lower amount of insulin could have done maybe years before. So this is a really key idea that elevated fasting glucose is a late indicator of insulin resistance. And this goes back to what I was saying, that we're finding a lot of students and their clients, they want to understand their metabolic health much, much sooner. They want to get on it long before they get that diagnosis of prediabetes based on their glucose numbers. So what are we doing to assess insulin response? Of course, we have the metabolic syndrome criteria, where we're seeing things like elevated blood pressure and dyslipidemia, increased waist circumference and glucose, that are all telling us that we have some underlying insulin resistance. And this is often accompanied by other symptoms like fatigue and craving sugar. But what about looking at insulin itself? Fasting insulin is available, but it's not traditionally been looked at that much because we're looking for diabetes diagnoses rather than this early predictive assessment. So looking at insulin really is kind of more of a, if you're looking at it within the context of subclinical prediabetes, then it makes a lot of sense. It's great information to have. It's not always reliable in diabetics because some diabetics will actually have normal insulin levels. It could even look quite low and high glucose, and that's because they may already be going into failure of that pancreatic endocrine function. So, but as an early indicator of insulin resistance, it can be very helpful. We're still kind of figuring out what optimal ranges should be because it has not been tested as much as something like glucose. So our standard range right now is considered to be 25 microunits per milliliter. But there's more and more leaders in this area suggesting that under 10 microunits per milliliter is a healthier maintenance place to be if we're looking to prevent metabolic conditions long term. Now, if you're looking to enter into weight loss, we may even want to pull that down lower because, again, insulin blocks lipolysis. So if we are trying to tap into those body fat stores for fuel, then we really need to pull insulin down quite low, right? So that we're looking at around six microunits per milliliter there. And then there are even some populations and some researchers that suggest even lower can be a more therapeutic, more of an aggressive therapy for some conditions like age-related neurodegenerative disorders where you see impaired glucose metabolism in the brain. Now, once we have that fasting insulin number, we can do another calculation that may even give us better information. It's called the HOMA-IR, and this is a calculation that you can do online. It's the homeostatic model assessment of insulin resistance, and we're using the fasting insulin in relationship to fasting glucose, and that's going to give you a little bit more of an accurate sense for insulin resistance. So we're looking for that to be under 1. And this is pretty nice because if you just have your kind of your basic metabolic panel, add on that fasting, then you'll be able to get that calculation done. You can also do a triglyceride to HDL ratio, which is just looking at the levels of triglycerides. If they are rising in relationship to our HDL, then that's a sign of insulin resistance. So we want that ratio to be down at 2 or lower. Okay, so moving on now in terms of what do we do about insulin resistance? Of course, at the NTA, Nutritional Therapy Association, we go into great detail around therapeutic foods, therapeutic nutrients and supplements, and different lifestyle approaches. So with the time that we have today, I thought I'd just mention a couple of ideas that really center about how we eat more than what we eat. The first one is time-restricted eating. It's getting a lot of attention in the research. It's not a specific diet in the sense that it's not eliminating one food group or another. It doesn't even necessarily restrict caloric intake by definition, although that does happen for a lot of people when they start to practice time-restricted eating. And we would consider this a type of intermittent fasting, where we are simply putting bookends on that feeding window. Now, when it comes to optimizing benefits for people with insulin resistance, prediabetes, type 2 diabetes, early time-restricted eating really has the best evidence. It aligns with the body's natural circadian rhythms. You see this in animal studies as well as human studies, where if we stack our caloric intake into the window where we are most active, where that species is most active, then you're going to have better metabolic outcomes. So when you see comparative studies looking at early time-restricted eating, you generally are going to see better metabolic outcomes compared to something like late time-restricted eating, something like an OMAD, where you're just eating one meal and that's dinner or something. And not to say that late time-restricted eating couldn't potentially have some metabolic benefits compared to, a 12-hour eating window, but really earlier time restricted eating is going to have more benefit. And there are several different mechanisms that would explain this. Pancreatic beta cells are more responsive during our active period, and that's because melatonin suppresses insulin production. And then our peripheral cells are also just more able to utilize food for energy when we're active. Another idea that we explore in the program is hunger training. This is the idea of measuring pre-meal blood glucose for eating, as an indicator of when to eat next, as a trigger for our next meal. This is so much different than just being concerned about that postprandial peak. The idea here is really to say, have we utilized that fuel from that previous meal? Let's allow our glucose and insulin to get down into those fasting kind of baseline ranges before we consume more food or caloric beverage. There is a stronger correlation between pre-meal glucose and waist to height ratio and BMI compared to postprandial glucose levels, which I think is quite fascinating. So again, we're allowing for lower insulin levels and we're allowing for lipolysis to take place, hopefully between meals. And the other real advantage is that it kind of trains hunger. It lets somebody know, okay, I'm feeling hungry. Do I actually need more fuel? Or is this driven by other things, maybe mental, emotional, hormonal, right? There's all sorts of things that can drive hunger. So this helps us to pair our response to hunger and our understanding of hunger with our actual energy balance in the body. Of course, a continuous glucose monitor makes this a lot easier, but it can also be done with just a regular finger prick. We also explore a lot around exercise and movement in terms of how do we pair that with food? How do we shape the way we're eating with how we're moving to optimize the benefits of movement? This is, of course, related to that insulin-independent glucose transport. One of the things we see is that if we avoid carbohydrates after working out for a couple of hours at least, that's going to maximize those insulin sensitizing effects of movement. And another tip or hack that we teach is to spread that movement out during the day, stacked with food intake. So if we can, let's say a client is willing to move 30 minutes a day, for a walk 30 minutes a day, rather than saying, oh, we'll just do that in one 30-minute block in the evening, we want to break that up and place it behind our meals. So if we can get in 10 minutes of walking within 30 minutes of a meal, we're going to have a greater impact on managing our glucose levels. So we'll see that we can kind of keep that postprandial peak a little bit lower and better utilize that fuel when we're taking it in. Oh, and of course, our program goes into a lot around stress management, sleep quality. What does a low glycemic, nutrient-dense diet look like for each individual, and therapeutic nutrients for blood sugar regulation and insulin sensitivity. Here are some references for anyone who is interested. I hope a key takeaway is just that we really are in this new era of a rich information landscape in which clients are very interested in a data-driven, proactive, preventative approach to metabolic health. So as practitioners, we really need to have an updated understanding, nuanced understanding of insulin response and insulin signaling, as well as a healthy toolkit for insulin assessment and a good handle on therapeutic approaches, holistic therapeutic approaches that leverage all of the diet and lifestyle strategies to help maintain metabolic health. I hope this was helpful, and I hope that you'll reach out and be in touch with the Nutritional Therapy Association. We are online at nutritionaltherapy.com and, of course, on all the social media channels, and we would love to be in touch. Have a great day.
For any questions or issues you may have, contact Avexia Diagnostics by email at info@avexiadiagnostics.com or by phone 5 days a week at extended hours, 8 a.m. to 8 p.m. Eastern Time at 888-852-2723. Thank you, Amanda, for this informative presentation. Thank you all again for joining us for this webinar event. Until next time, from everyone at Avexia Diagnostics and Nutritional Therapy Association, stay healthy, stay safe, and we wish you all the best on your pathway to wellness.